State your name for the record before speaking or responding to questions. The first item is an overview of the Health Department and the Director's Office. Good morning. We have folks from the Health Department here, including Director Rachel Banks.
Good morning. Thank you, Chair. Good morning, Commissioner Moyer, Singleton, if you're listening, and Brim Edwards and Jones Dixon, if you're listening as well. For the record, my name is Rachel Banks, and I get the honor of being your Health Department Director. We're here to talk about the Health Department overall budget, and just want to say welcome to Health Department Budget Days, and we'll be back tomorrow to talk more in this afternoon as well. So I just wanted to acknowledge up front some of the questions that I know commissioners have had and where you'll see them in this presentation either this morning or later on today. For example, on slide 27, we'll be talking about the total number of impacted FTE, as well as the ratio of represented to non-represented impacted FTE. And you'll see that we'll discuss more as we review how we looked at SPAN, and ultimately that we're taking a higher proportion of management reductions relative to represented employees. On slide 28, you'll see a list of the major reductions we took. The chair asked for a 5% reduction. We ended up with a 4.4% general fund constraint and a 5.9% total constraint. On slides 11 through 17, you'll hear, and throughout, how we incorporated equity lens into planning. And on slide 31, we'll discuss updates to vacancies. As you know, these have changed since the last report, and so we'll talk there. I will just say you're going to hear a lot of content. I've heard that the Health Department likes to talk and use a lot of words. And I just want to say we're very excited and proud about the work that we've done. But the major thing is that I would want folks to know is that in this budget, we focus on preventing the most harm, protecting those who need us the most, and fulfilling our unique role to serve all 800,000+ folks in Multnomah County who live, work, or come through here, whether they know it or not. So if we go to the next slide, I am going to introduce our fabulous CBAC Chair, Rosalie, and thank all of the CBAC members, the Health CBAC members, some of which are here in the audience today. They have been tireless advocates and listeners to all of the content that you're going to hear and more. And Rosalie, our fabulous chair, has been on the Health CBAC since January of 2021, started chairing it in January of 2024. And I'm just going to read a whole spiel, Rosalie. Yep, gonna do it. So Rosalie has experience as a consultant specializing in behavioral health, strategic insight, research, and her training in psychology and work with developing novel intervention for children at OHSU has brought invaluable insight to the work that we do in the CBAC. We have benefited tremendously from your tireless commitment to health equity, population health, and focusing on the whole picture, including the infrastructure and the engine that we need to serve the people that we serve. This is Rosalie's last year as our Health CBAC Chair, which is sad, but we're so thankful for what you have done these many, many years. And with that, I'll turn it over to you.
Thank you so much, Rachel. And the Health Department, I appreciate you guys and all the support that you guys have given me and the CBAC through the years. Good morning, commissioners. My name is Rosalie. I've been honored with the privilege to volunteer in service to my community for the last 6 years. And again, as Rachel has just said, this is my final year presenting as the chair of the Health Department Budget Advisory Committee. So our committee brings together 8 community members with backgrounds spanning behavioral health, health administration, housing justice, law enforcement, social work, public health, and equity advocacy. We had planned to have some CBAC members join us today, but unfortunately they were not able to make it just due to family circumstances and personal and professional endeavors. So I am supported by our members of our committee that could not be here today. That includes Gwen Pizzoni, Valencia Ocampo, Hannah Studer, Mina Gilson, Peter Brown, Talia Giardini, Valencio Campo again, and Veronica Robinson. Together, we represent the diversity of this community and the communities most directly served by Multnomah County Health Department. Our work is grounded in 6 values, including racial justice, intercultural intelligence, ethics, and values that we applied through every recommendation in this report. So on behalf of the Health CBAC members, we thank you for the opportunity to present our recommendations. Next slide. So our planning launched in September 2026. We received monthly presentations from Director Banks, division leadership, and subject matter experts. We evaluated 11 programs proposed for reduction, ranked each independently against the county's equity rubric, and reached consensus through deliberation. These recommendations are a part of that rigorous process. Next slide. So Chair Vega Peterson's executive budget, you had described a $67 million funding gap in homelessness services, an $11 million general fund deficit. For the health department, this pressure continues to mount. Declining property tax revenue, significant reductions in federal and state funding, the loss to Care Oregon's delegation revenues, and changes to the county financial assistance agreement. What this means in plain terms is that Multnomah County is being asked to do more with less at precisely the moment when the community need is the highest. We're in the middle of a measles outbreak trajectory that Oregon has not seen in 3 decades. Eviction filings have doubled from pre-pandemic rates. Fentanyl continues to devastate families across every zip code. Federal immigration enforcement is separating families, compounding mental health crisis in our immigrant and refugee communities, and the federal government, which this country has historically relied on as a partner, is actively retreating from its public health commitments. So 3 things that we've seen that define this budget moment is first, an uncertain financial future. So as I had previously said, declining general fund revenue, significant federal and state funding loss, and the end of the Care Oregon delegation revenues, all compounding simultaneously. Second, demand for services are rising, especially amongst communities with the highest barriers to care at the exact moment that we're seeing reduced capacity. And third, progressive cuts to data analytics are eroding our ability to evaluate what is working. And I've seen this like progressively over my time here is unfortunately that we've had to make these cuts. And we just urge the board to treat this as a long-term structural risk. Next slide. Our feedback organizes around 3 pillars: direct service for vulnerable populations, because these cuts to crisis intervention and food security shift costs downstream and don't eliminate them. Prevention and community investment, because every dollar cut from early intervention generates multiples in crisis response. And the impact to culturally specific services, because they're not supplemental programs. They're often the only door that certain communities will walk through. And when we close them, we lose trust that took decades to build. Next slide, please. And after reviewing the department's transmittal letter, budget overview, and proposed reduction, the CBAC is broadly supportive of the department's decision-making approach and the framework that has been applied to navigate an exceptionally challenging environment. We ranked 11 programs in reduction and priority of restoration, largely aligned with the health department's proposal. So number 1 was culturally specific outreach and stabilization treatment. We believe this is a housing justice investment and a racial equity imperative, and so it was our highest priority for restoration. 2, women, infant, and children program, where we would see a reduction of 1 FTE for administrative support. Number 3, community-based mental health services for children and families. This is the only culturally specific behavioral health provider serving specifically African American, Latin, LGBTQIA 2+ youth in this region. And we want to extend our sincere appreciation to Commissioner Brim Edwards for championing this program last year. Moreover, thank the board for the continued support of this program over the years in finding permanent funding for this program, as the chair had stated in her FY27 executive budget. And as I said, over the last few years, this program is prevention at its best. It reduces crisis, interrupts school to prison pipelines, and provides necessary resources for healing. Programs 4 and 5, early childhood mental health and harm reduction. Next slide. Programs 6 through 11, community health worker training, behavioral health crisis services for military and youth, corrections behavioral health, 3 operational infrastructure positions, which are detailed in the report, each represent a compounding loss. And I believe our last slide. So we want to recognize the real progress. Stipends have been extremely helpful. Improved onboarding, better access to information have strengthened this committee. The CBAC exists because of you, the board, and the belief that the people most affected by public health decisions should have a genuine voice in shaping them. So we ask respectfully for 3 things moving forward. Is first, that while we're super, super thankful for the stipends, but the stipends that honor our members' time, I would suggest increasing the stipends to help attract board members, participation, especially those receiving direct services. I think Commissioner Moyer, you had kind of alluded to that last year. Really, really proud of the diversity that we see on our committee, but I think that would be super helpful. Second, consistent report development timelines. We lost 1 week in development timelines as in this particular cycle, and it creates an extraordinary pressure in terms of just like creating the recommendations and extraordinary pressure on our volunteer committee. And then additionally, the health department is, I think in conjunction with that, the health department is one of our largest and most complex departments. So I think time to make those recommendations should reflect that scale. And then finally, the Health CBAC Committee recognizes the difficult position that Health Department has been tasked with. We want to thank you for thoughtfully working through this and protecting statutory functions, advancing equity, and preserving frontline services. Chair Vega Peterson, we support the proposed budget that prioritizes programs already working and making an impact. And despite the economic outlook, we're hopeful that people will see the intentionality and the care that you all have and what we want to preserve here in Multnomah County. And we hope that folks will, move here and make the investments to contribute to our county. And we hope that these programs will be restored when budget allows, and to restore our workforce and to provide solutions and care that vulnerable communities deserve. Thank you so much.
Thank you so much, Rosalie. And you have been, how many years has it been? 6. 6 years. I mean, like such a long time, like such a long, more than half the time I've been here. And your work on the health CBAC has just been incredible. Your leadership has been incredible, especially with all the changes that have been happening with CBAC. And I just really want to show my appreciation for your
I appreciate that so much. And I appreciate the space that you guys have made. Like even the tables bringing you guys closer is super meaningful. So I appreciate you guys.
Thank you.
see how fabulous our CBAC is. Thank you again, Rosalie, and the members of the CBAC. I mean, I just think that those words and even just the hope and inspiration you brought about acknowledging the tough choices, but also hoping and manifesting better economic times and restoration of some of the things that we're going to lose, I think just says everything about your leadership. As Rosalie noted, we had to make difficult decisions this year and weren't able to restore everything, obviously, that the CBAC recommended, but certainly integrated the values, the approach that they brought forward and the leadership. So thank you again. So now if we go to the next slide, we're going to dig into the health department overall budget before doing some division-specific thing. And I just want to say this budget represents so many wonderful things that we get to do across so many settings that you'll hear people talking about. But of course, it also represents loss. And the decisions are difficult and inevitably are producing grief for us, for impacted employees, for community members, and I know for all of you also. I just wanted to acknowledge that. To minimize the impact, we've done a number of things, and part of that is focusing on the intersection of our statutory requirements as well as our equity efforts, brought together cross-departmental efforts wherever we can to minimize, to maximize our collective approach and minimize any competition between as much as we can, gain some efficiencies. So that shows up in our work like overdose prevention, and these efforts really create a greater whole than the sum of our parts and allow us to focus directly on preventing harm. So if we go to the next slide, I will talk to you about what we do. So our vision is thriving communities that nurture the health and resilience of every single person at every single point in their life. We do that by working with the communities to advance health equity, protect the most vulnerable, and promote health and wellness for everyone. We are responsible for the many in the health department, and we are responsible for the few. We are responsible for the meta, the things that every single person experiences: air, water, food, and we are also responsible for the micro and individual level care, and we do that at all times for every single person at some point throughout every stage of their life. There are many health entities in this community, but we are the only one that are responsible for every single person. So our client population, if you will, is every single person in Multnomah County, which of course we're very proud of. We do this through three major mechanisms, or three pillars, like you'll see. One of them is policy, so that's working with you all as the Board of County Commissioners, who is also the local public health authority and the local mental health authority. Those policies correct health inequities and protect the health of everyone. We do that through population health, so assessing the health trends. This is our assessment, our epidemiology, our data and analytics that Rosalie mentioned, understanding what we're seeing now, predicting what will be coming in the future, and most importantly, measuring what's working, and when we see the decreases in the things we want to see decrease and the increases in the things that we want to see increase. We also do that through community engagement. So we're marrying, blending, if you will, science and community wisdom to bring together community-driven solutions. And then we offer direct services. We do this in a variety of settings. It's physical healthcare, behavioral healthcare, oral healthcare, correctional healthcare, and really excited about that work as well. So we, again, focus on those where we can have the most impact, those who need us most, and the work that only we can do. So if we go to the next slide, this is one of the ways of how we incorporate equity into our work. And it's really the North Star, that meta of what are the outcomes that we are seeking and where can we have the most impact. What you're looking at, it's a bit of a busy slide, but I'll walk us through it. These are the leading causes of death in Multnomah County from 20 to 24. So this is really that meta that I was talking about, the long-term North Star. We focus on the leading causes of death because this is where we can have the most impact, and this is where we see the most egregious inequities. So in this slide, these are ranked leading causes of death. On the left, you have Multnomah County as a whole, and the top 5 leading causes of death. And then you have throughout the graph that broken down by race and ethnicity. So the top cause of death overall for the county in the darkest blue is cancer, and then moves it, the lighter colors are the lightest, it goes down by lightness, if you will. So when you look at the leading causes of death by race and ethnicity in this table, you'll notice a lot of variability, but I want to point out a number of things. First, that cancer and heart disease are in the top 3 for any community, or all communities. But unlike those, there are some communities where COVID, diabetes, and liver disease pop into the top 5. In addition, you'll see that unintentional injury was in the top 3 leading causes of death for Black, African American, Latino, Hispanic, and white populations. And looking at this, we can see glaringly where inequities pop out. So we continue to have an overdose crisis in Multnomah County, and that is the top cause of death you'll see for the Alaskan Native and American Indian population is unintentional injury, which is largely driven in that category by overdoses. So that's why you're going to hear how we've maintained our cross-departmental efforts in overdose prevention. But we always, when we look at this data, want to pause, because these are our brothers and mothers and sisters and fathers, neighbors and friends. The data that I'm going to be walking through is a lot of years of life that we can prevent and that we focus on, and don't want to walk through it like it's just like numbers on a graph. We also know that recovery is possible and that we can make a difference here. So that's why we're staying the course. If you go to the next slide, this is what we call years of potential life lost. This is also from 2020 to 2024. And this is from all causes, including unintentional cancer and heart disease. So the work that we do doesn't show up immediately. It takes many years sometimes, or decades, to change the health outcomes that we're seeking to change. But what you'll see in this slide is, for example, the inequities are staggering. So 21,438 years of potential life lost per 100,000 in the American Indian and Alaskan Native community. 21,000 years. It represents thousands of missing elders, parents, youth, birthdays, and we know when someone dies young, they cannot pass down those traditions, those stories, and for these communities with high years of potential life loss, that is significant loss. And they result in that loss of cultural knowledge and resilience. One of the ways that we think about this, because they're so high, is just seats on a table. And so, for example, for the Black community, if we were sitting around, if this was our dinner table, there would be 2 missing seats, 2 empty seats for every 1 seat that we see in our white communities. I just want to point out a couple things. And if you look at the all-cause mortality for Black, African American, Alaskan Native, and Hawaiian and Pacific Islanders, that's where we see the most significant premature death. And you can see that for all communities, the rate of years of life loss was higher for unintentional injuries than for some of the other areas. You can move on to the next slide. So Rosalie talked about this a bit, but what we are facing are stacked reductions. And these stacked reductions come at a time, as mentioned, with increasing community needs. So that's why we're here to do the things that we can and tackle the hard stuff. We clearly have rising costs. As you all know, we have general fund reductions. We're also supportive housing services reductions. We have changes in the County Financial Assistance Agreement, CFA, that we'll talk more about, that have forced us to reallocate funding in a way that prioritizes certain populations but decreases funding for other things that we do well and love to do. Obviously, federal fund uncertainty. We have a coordinated care reductions, some of which we took in the last fiscal year, earlier this calendar year. And we have declining access and uncertain access to beginning working capital. So we've had some programming that has been on beginning working capital that we are no longer able to pay for or at the level. And then we have some structural deficits that have been in place in the health department budget for as long as I've been here. And one of them is in corrections health, which Valdez and Tony will talk about, where we've seen year over year that our actual costs of providing care are higher than the budget. And with the budget declining overall, we really focused this year on looking at our actual spending in places we were overspending, like corrections health, the health officer, and places where we had underspending, some in behavioral health, to align our budget with what we see in our actual spending, because we know we just have less and less wiggle room. So with that, I'm going to turn it over to Angela.
Thank you.
Go to the next slide.
Good morning, everyone. Angela Henderson, Deputy Director of the Health Department, focus on strategy, policy, racial justice, and equity. I'll bring this a little closer. So I'm going to talk about our budget approach and how we integrated equity into our budget decisions. And what you see here are a series of core decision-making principles that we use to help guide our deliberations, our considerations, the impacts, and also the efficacy, if you will, with respect to impact and what we're seeing in outcomes related to some of our provision of services, as well as the decisions that we're making, and so, or have made, I should say. And so we, together with a cross-section of teammates from across the entire department, across the, the breadth and depth of the department, worked with that team of people to refine our budget rubric overall. So we introduced our budget rubric last year, and then we built upon that in partnership with, again, across the strata of our organization, and both vertically and horizontally, if you will, to arrive at these core decision-making principles and other considerations. And so it was really truly a collaborative process by which we evaluated all of the decisions, the impacts, et cetera. And we are centering also the voice of not only our internal community members, but also the voice of the communities that we serve, those with very real lived experiences related to the work that we do in the health department. And this was, our budget decisions overall were shaped by both qualitative and quantitative data, some of which Director Banks spoke to a moment ago, but also the qualitative insights, again, the lived experiences experienced by the communities that we're serving and the populations that we're serving. And we use that information to inform the decisions that we made. And so we focused on what community needed and what community expressed that they needed and prioritized for services for us. Again, those voices from the most vulnerable and, again, historically perhaps underserved populations as well. And so in so doing, that's how we very intentionally integrated equity into our decision-making and advanced and operationalized racial equity as well. And by doing so, we also lived up to our value of inclusively leading with race as well in some of these decisions and in the services that we're providing. And also, as stated here in bullet point or dot point number 2, we also upheld our statutory responsibilities, so again, honoring our unique governmental role, and then also looking at what we were required or mandated to do and statutorily required to do. What are those responsibilities, and protecting those, obviously, those services that we are required by law or mandated statutorily to do. So we did that as well. And then also, as Rachel mentioned, with respect to the previous data slide that we saw, where unintentional injury was also one of the top 3 leading causes of death across our communities of color. We were also granulated, that's an interesting term right now. We were grounded in granular quantitative data, like you saw on that slide, and used that to continue our focus on preventing unintentional injury, illness, and death, particularly in communities that are already experiencing the highest or greatest inequities and therefore health-related burdens. Next slide, please. So as I mentioned, overall, our budget was definitely an inclusive process, engaging both our Community Budget Advisory Committee, internal and external community voices, again, getting that qualitative insight as well, and being guided by the quantitative insights. But we also had to address the structural budget issues that Rachel just spoke to a moment ago with respect to a couple of our divisions, and being able to ensure that we are providing those very much so needed services that our community has expressed, and we also see every day that we definitely need. And so we aligned our budget to better reflect our actual spending realities, and Rachel alluded to that when speaking to both the correctional health and other divisions that you'll hear from later. And we maintained also fiscal discipline, is what I'll call it, by being forward-looking and having that be the lens through which we not only met the chair's 5% county general fund constraint, but we also were looking at more long-term sort of planning and investment strategies and planning to ensure that we are able to sustain these services beyond just the upcoming budget cycle or the current budget cycle. And we looked for savings through operational improvements by looking at vacancies, assessing our management span of leadership, and also looking for ways in which we could consolidate different administrative functions as well, all enabling us to not only meet the constraint, but again, be future focused in how we can continue to sustain the services that we are providing. And Rachel, you did mention this a moment ago, but I'll reiterate it. We also continue to assess and find ways in which we could address the other structural funding issues that were spoken to earlier, and the disproportionate underfunding of critical infrastructure, some of which is actually mandated as well. And so building on this, with the next slide, I'll speak to how our equity-centered approach and principles translated into specific decisions. And so first, as you see across the top there, what I would love to sort of emphasize is that our approach, first and foremost, was grounded in our declaration of racism as a public health crisis. At every stage, we asked, are we inclusively leading with race, and what are the equity impacts of these various decisions that we're making? And this was not a one-time lens through which we asked those questions. We did that throughout each phase of our budget deliberations, where we were also considering the impacts, and we did equity assessments throughout the entire process. So I just want to emphasize that to show the degree to which the health department has really, truly, intentionally evaluated the impact of these decisions, and we did not take that lightly, because with that comes considerable cost, if you will. And so this was not, again, a one-time lens, and we applied this continuously, as I said, throughout all of the decisions, as well as the trade-offs and the priorities that you will hear in forthcoming conversations with our teammates. And the data is where we started. So the data itself, they clearly show the differences across the various communities, as you saw with the leading causes of death slide, for example, and the years of potential life loss as a result. And they help to guide us to prioritize those communities experiencing those greatest inequities, and also, more importantly, the barriers, if you will, to optimal health for each of those communities. And so we partner closely with our CBAC, again, the Community Budget Advisory Committee, which is comprised of communities most impacted, and they also bring very much so qualitative and lived experiences. And this collaboration helped to ensure our budget reflects community priorities and needs, and also I guess sort of helps to ensure that we are not imposing, if you will, institutional assumptions, and instead are guided by those qualitative and quantitative data. So given the compounding constraints also that you saw on the slide that Rachel presented a moment ago, we also conducted as I mentioned, equity impact assessments on all potential reductions. And this helped us to avoid disproportionately further shifting harm into communities that were already experiencing health inequities. And we prioritize funding by our statutory responsibilities and core services, as I showed in that Venn diagram earlier. And while at the same time, we sought to minimize those impacts, as I also spoke to our culturally specific programs and services in particular, and those particular strategies. But I also want to be really clear and just speak this, into reality, so to speak. A key reality of that is because the health department has really, truly, intentionally embedded equity into everything that we do in our core services, our functions, we're led by that. Those are our values. We've also fought really hard over years to have a very diverse workforce. And due to that, the clear reality is because we are so deeply steeped in equity, it was virtually impossible not to also impact equity at the same time. So we are going to see, and we're going to hear about the implications of some of the choices that we had to make for not only the communities that we serve, but also our internal workforce community as well. Because again, equity is sort of I will say it's the fundamental core value upon which we deliver those services. And advancing equity is not separate from what we do. It is, again, fundamentally what we do and core to our mission. And so now I will turn it over, I think, back to you, Director Banks.
Yeah,
we'll talk about the budget in a while.
Yeah. Next slide, please. So here's a snapshot of all the fabulous things that we do and the people that we serve. You will hear from all of these areas later on today and tomorrow. So in our integrated community clinical services, also community, we've had over 250,000 visits across all the clinical programs. With our call center, we serve over 85,000 calls. In corrections health, we serve over 17,000 people annually. Our finance and business management area is estimated to execute 625 contracts, or I should say administer 625 contracts to do community-based work. Our health officer team responds to over 1,500 medical examiners seen responses in operations. We help support over 1,500 FTE across our 34 sites, 57,000 folks in WIC in our public health division, over 100 outbreaks investigated, and issue over 25,000 licenses. And in our community health improvement plan, we work with over 13 community-based organizations and 8 advisory groups or coalitions to bring together that plan. So if we go to the next slide, we're going to do some deeper dive in overdose prevention, both to show what the numbers are looking like and also to show how we work across our health department to keep getting these numbers down. So this is a key part, as Angela talked about, of the equity impacts that we're seeing. These overdose deaths, quite frankly, are yanking down our life expectancy, and are so many years of life lost that we know we can keep. And that's what we're doing. So the overall trend you'll see here is going down since we had a peak in 2023, where I remember sitting here at this table talking to you all about what we were going to be doing, both through an emergency declaration, and you asked Commissioner Brim-Edwards for us to keep our foot on the gas, and that is what we're continuing to do here. So clearly our trends are moving in the right direction, but we are keeping at it. There are obviously cyclical peaks and valleys in this. A lot have to do with the drug supply. So I'm going to talk about the interventions that we have control over, and also just acknowledge that there are a lot of things that we don't, that have to do with the potency of the drugs, what drugs, so on and so forth. Bless you, Commissioner Singleton. So if we go to the next slide, this slide shows the latest verified overdose data, the verified data through July of 2025, with provisional data through April 29th of 2026, with an overlay of naloxone distribution through December of 2025. I just, as a reminder, the overdose data lags a bit for several reasons, including the time it takes to do toxicology reports and state autopsy. So until the numbers are verified, they might change a little, and I have to say that for my epi folks, because that's very important for them, that you all know. So what you see here is that the black line is overdose deaths from opioids, so like fentanyl or heroin. The green line is overdose deaths due to stimulants, so that's like meth. And the blue bars are the number of naloxone kits that we've distributed to community partners throughout the department. So we know that naloxone is just one intervention in bringing down overdose, but we know it moves the line. So we really wanted to showcase this because it's an example of how these budget decisions support continued progress on health outcomes. These are health outcomes that take years, if not decades, to change, but we can see in various program offers how we're continuing to do that throughout our budget. I do also want to mention again, some things that are working against us. We have a federal administration who is making decisions that make this work harder, particularly like prohibiting fentanyl test strips and some of those things. To combat that, we have done what we can, including purchasing a Randox system, which can detect through death scene investigations and whatnot, can detect some potency or lethality, increased potential lethality in the drug supply, in which we are then able to kind of get that information out and quickly message so that folks understand when we're seeing some sort of negative trends through our investigations. All right, so let's go to the next slide, just please.
Before you,
Yeah.
just so I understand, this number of deaths per month.
This one? Yes. All right, next slide. So really, to get big outcomes, we have to have comprehensive approaches that work at every single level at the same time. We've seen that throughout public health best practice. And so here is a snapshot of the various ways that we work in every single area to be continuing to yank those numbers down. So in the director's office, we lead the overdose prevention planning and response and coordination. Our integrated clinical services provides medication-supported recovery for the folks that they see. Our finance and business management administers the contracts for community partners to provide sober housing, naloxone, and a variety of things. Our operations team coordinates naloxone distribution across the department. Our behavioral health team administers the deflection program, offers a variety of different treatment programs, and recovery supports. Our health officer coordinates our emergency medical system that responds to overdoses, as well as our death scene investigation. Our public health team operates the harm reduction clinic, wound care, and information and referral connections to treatment. And our corrections health provides medication-supported recovery for people currently incarcerated or leaving, as we know that is such a crucial time and a high-risk time for folks coming out of carceral settings for overdose. So every division, as you can see, has a part to play, and it's really the strategic coordination of these elements that allows us to make really big impacts and challenge the things that are outside of our control and work diligently to do the things that we can. If we go to the next slide, I'm going to use just one other example of how we work across the department on key issues, and this is emergency preparedness, which is a core competency for a governmental health department. And our budget supports this in a number of ways as well. So I talked earlier about the long-term nature of our work, but we also are responsive and have to respond at the drop of a dime. And in order to do that, we need to be prepared. So we know, of course, that one of the dangers is overdose, but we have a variety of them that come. Rosalie spoke about measles. There are other things that have to do with heat or climate or any of the different things. And these are some of the ways that we support that work. So we do public information. It's a key element to what we do, letting people know what the harms are, how they can stay safe. We do that in various languages in real time. We work as part of a regional response because many of the things that we're responding to do not stop at our front doors. We convene health systems to ensure that if care needs to be triaged, we can do that, or if more, health seats are needed, spots are needed, that we're working with systems across the region. We do planning, tabletop planning, COOP planning. We monitor disease outbreaks, prevention supports, and of course provide the critical care in any sort of emergency, and continue to do that in 24/7, 365 days a week. So that's a snapshot of what we do, how we do it, and how we're trying to bring together some of the pieces. You'll hear much more from my fabulous colleagues that are doing deeper dives in the division-specific work. But with that, I'm going to turn it over to Trista to talk numbers.
Thank you, Rachel. For the record, my name is Trista Zugel, and I'm the Health Department Budget Director. And I use she and her pronouns. We're going to move into some of the budget detail in the next few slides. The total operating budget, proposed operating budget for fiscal year 2027 is $503.8 million. This represents a decrease from the fiscal year 26 adopted budget. This decrease is driven mostly by decreases in federal grants, the ending of one-time only investments, reductions in funding from our CCO partners, and general fund reductions. So these are the stacked reductions that Rachel talked about earlier. New one-time only investments include $150,000 for a contract to provide specialized outreach outside of the central library, and $362,000 for the ambulance service plan evaluation continuation. New ongoing investments include a roughly $418,000 backfill for school-based mental health, which maintains all client-facing positions, $677,000 for transition services for individuals leaving county jails, and $541,000 in permanent ongoing funding for the gun violence response team. The Health Department is grateful for these investments. Next slide. This slide shows you how the fiscal year 2027 budget breaks down among funding sources. You can see that our general fund declined 1.9% year over year, driven by county general fund reductions and a decline in our indirect revenue, which I will discuss a bit more in a future slide. Our Fed State Fund declined by 9.5%, largely because of the loss of Care Oregon Coordination Delegation, the Care Oregon Coordination Delegation Agreement with Behavioral Health, and the spend down of one-time only resources for the Deflection and Sobering Center. The FQHC fund increased slightly year over year, but due to inflation, this increase actually represents a reduction in staffing, which they will be discussing more in depth with you. Preschool for All funding was eliminated in behavioral health, as DCHS will implement a different model for behavioral health services for Preschool for All clients. The Preschool for All fund increased slightly in public health to fund nurse support for certain Preschool for All clients. So that is the Preschool for All funding that remains in our budget. Finally, the department's supportive housing services allocation, which is spent exclusively in the behavioral health division, declined by 46.2%. Note that a large amount of that reduction is because there was an approximately $7 million one-time only investment in fiscal year 2026 to support the construction of a recovery center. Next slide. You will see the dollar changes from the previous graph represented in this FTE graph that shows the department's continued decline in FTE count, which dropped 5.8% from the fiscal year 2026 adopted budget. In our presentations today and tomorrow, each health department division will discuss in greater detail the impact of these FTE reductions. Next slide. So you can see by this next slide, which gives you the operating budget by major category, that the vast majority of our funding, just over $290 million, will be spent on county personnel, with an $86 million investment in contractual services, which is used mostly by our nonprofit partners. The balance of the budget is spent on internal services, such as rent and utilities, and purchases of materials and supplies. Next slide. I wanted to quickly orient you to the impact of changes in our indirect revenue. As a reminder, indirect is a general fund revenue that departments receive, and it is a method, indirect is a method used to recover overhead costs from grants and other federal and state funded activities, including Medicaid activities in ICS as well as other divisions. You'll see that our indirect rate declined year over year, but in addition, our budget included less indirect eligible expenses, leading to a reduction in available general fund revenue of about $1.9 million. This required the health department to reduce general fund spending by more than the requested 5% constraint. You will see the indirect related reductions listed as internal general fund reductions in our reduction tables, and a full list of resulting reductions is provided in the appendix. Next slide. Moving on to a high-level description of some of our significant program-level reductions. I just want to note that these are not all of our reductions, but some of the larger and more significant ones. I also want to note that these will be covered in much more detail in the presentations that you will receive today and tomorrow. The harm reduction program was reduced by roughly $1.14 million. This item eliminates public health harm reduction outreach capacity. It also combines clinical positions and support across STI and harm reduction clinics, eliminating 5.8 FTE, but retaining clinical services across both clinics. The Corrections Health Behavioral Health Services program was reduced by $875,000. And 3.4 FTE. This is a partial reduction of the program, which is charged with providing mental and behavioral health care in the county's jails. These changes eliminate difficult to hire positions that were long vacant and also improve the span of leadership as well as aligning with current staffing needs. The Behavioral Health Culturally Specific Mental Health Services program is reduced by $850,000, and this eliminates funding for a culturally specific transitional housing program for Black and African American adults. The Health Department Director's Office was reduced by roughly $1 million. The Office of Health Equity is transitioning from directly delivering community-based workforce training, which is now widely available through other community partners. This transition will ensure we have continued resources to support culturally specific coalition work and focus on advancing community health planning as well as do internal WESP work. The Director's Office also eliminated a Manager 2 position to improve the span of leadership and reduce project management capacity. The Early Childhood Mental Health Program is reduced by roughly $470,000 and 2 FTE. This program, which serves children in early childhood education programs, chose to reduce 5 mental health consultant positions from 1 FTE to 0.8 to mitigate the impacts of reductions while retaining staff during the school year. So those employees will now not work during the summer months. There's also a reduction of 1.0 FTE culturally responsive mental health consultant and an elimination of a contract for early childhood treatment services. The Women, Infants, and Children program is reduced by $452,000 and 3.6 FTE, a reduction that eliminates some administrative and client support with a redistribution of this workload to management. Next slide. All right, the next slide shows you some of our significant reallocations. That's when we stop funding a certain function in order to fund another. And as Rachel mentioned, a significant part of our fiscal year 2027 planning was to better align our spending with our budget. Because behavioral health consistently underspends their total allocation for general fund funded contracts, we chose to reallocate some of this general fund to other key needs without eliminating services. We did this to ensure that we are making effective use of all of our general fund to meet the needs of our programs and employees. Here the funding, the behavioral health funding, is reallocated to cover naloxone purchases in the overdose prevention and response program offer, 2 medical legal death investigators in the medical examiner's office, and cover costs at the Behavioral Health Resource Center. Next slide. Additional reallocations, including taking reductions for efficiencies in the communicable disease program and in the communications office and the health department director's office, were used to fund a department-wide emergency management position to support emergency preparedness, the addition of contracted staff to expand capacity in public health to support real-time response from academic partners and federally trained CDC researchers, and needed payroll and labor relations capacity in human resources. Next slide. As you can see, year over year, our budget represents a reduction of 94.96 FTE. We focused a lot this year on our span of leadership ratios in our decision-making. This led to a higher percentage impact on non-represented staff, which are reduced by 7.14%, than represented staff, which are reduced by 5.48%. Following the budget and impacts for fiscal year 27 and the end of our COVID programs, we have seen a disproportionate impact on our diverse workforce in relation to our overall workforce. Several factors may be contributing to this, including our focus on hiring a workforce that reflects the communities we served, impacts based on seniority, and funding changes within Oregon from federal that will affect our culturally diverse programs. I just want to note that later, shifting gears a little bit, vacancy information is provided later in the appendix for you. I just want to note that we will continue to provide you with updated vacancy information because at normal times that vacancy information changes day to day, but at times when we're managing layoffs, it also changes it changes more quickly than normal, I should put it that way. Please note that many of the employees whose jobs are eliminated may have rights to positions in the department, some of which may be vacant at this time. And then back to Rachel.
Thank you. So the next slide is appendices, and thank you, Tasha. We're going to now dig down into the director's office, operations, and finance and business management. So these areas are necessary to support the frontline work, keep us all rowing in the same direction. This is where our community partners get paid for their critical work, where Medicaid revenue is collected, and our employees receive the support they need to do the jobs that they do every day. So it is in them that you really see a manifestation in these areas of our core capabilities. Welcome, Derek. Our business excellence and the engine that support some of our key focus areas like integrated impact and incubation and capacity building for community partners. So if we go to the next slide. This slide gives a snapshot of the operating budget and FTE of each division across the health department. The largest area is the Federally Qualified Health Centers Enterprise Fund, followed by our behavioral health and public health divisions, corrections health, and then our kind of core areas that we're going to be talking about in this presentation. Next slide. I will just mention one thing on that previous slide with the FTE. Oh, thank you, this one, thanks. Is that we've seen significant reduction in our vacancies year over year. So Trista kind of alluded to that. We've seen this specifically with the available vacancies. So for example, over the past 3 years, we've seen the vacancies decline at this time from 369 to 177, including new positions. So that was just one thing I wanted to note. All right, and then we can go to the next slide, and then we'll just keep going. So this is how the director's office delivers. So again, these are the core functions that support the work of every single division that you're going to be hearing about. It includes executive leadership. This is things like policy, community planning, program development. It includes in our Office of Health Equity, our community engagement, and our WESP implementation work. It includes department-wide initiatives in our strategy and grant development, whether that's things like emergency preparedness or overdose like we have talked about. It includes our health communications. This is public information officer support, health communications, behavioral change, health communications, which I will add is one of the most cost-effective ways to get information out to 800,000 people at a time, 50,000 people at a time. And we do that, again, in multiple different languages in real time and with, ongoing things, whether it's our measles communications or recovery is possible communication campaigns and all of those different things. So really what this looks like in practice is setting up the work to incubate the development of the deflection program and then iterating on it as we had a year's worth of outcomes and heard from you all about the things that you wanted to see. It looks like responding to the complex policy questions or inquiries that you all have as a board of county commissioners and as the local mental health and public health authorities. It looks like ramping up a communications campaign for whatever outbreak we're working on. And it looks like connections to community leaders, elders, across the whole department to stand up something like a response to a heat event or an overdose crisis. So if we go to the next slide, what you'll see here in our overall operating budget and FTE is a decrease in both Fed, state, and county general fund. Trista talked about some of that earlier. There are both real FTE reductions in here in terms of FTE that we'll talk about, but there's also a decrease that represents the moving of HR out of the director's office. So with that, I'm going to pass it over to Angela.
Thank you. Next slide, please. Thank you. So the health department continues to navigate, as Rachel mentioned, external uncertainty and significant turbulence at the federal level, particularly related to federal policy and funding, along with broader uncertainty across Fed, state, and other funding streams, requiring multiple waves of programmatic redesign. And so we continue to operate in an environment also of public distrust in government and public health expertise, which impacts how our services are both received and accessed. And so we respond to this by staying focused on our core services and statutory roles and leveraging partnerships and credibility as an academic health department, or by strengthening partnerships with, for example, the Western Health Alliance. And as an academic health department, we've established new partners, enabling us to leverage their expertise to strengthen public health and healthcare workforce infrastructure and to respond to gaps in federal research and fact-based health information, and providing opportunities for reciprocal skill building to develop the next wave of governmental county health leaders, if you will. We also strengthen collaboration, as I mentioned, through the Western Health Alliance, connecting and staffing emerging regional committees, and also those committees that were, I guess I should say, those committees that were needed to fill the gaps in the federal health work. An example of this would be like for vaccine recommendations, for example, and leveraging the purchase of vaccines. And so we also partner with and leverage trusted community messengers to improve both reach and effectiveness. And we accomplish this through our established culturally specific coalition work in the Office of Health Equity, as well as throughout the other divisions as well within the department, to address health misinformation and respond to emergencies and understand key health priorities directly from communities. And an example of this, as Rachel mentioned a moment ago, that I'll just elevate again, is the measles outbreak. And also with respect to how we would do that in a culturally specific way, an example of how we are elevating and increasing more awareness and also correcting misinformation is measles outreach, in particular to our Slavic communities, and that is happening right now. So in partnership between the Office of Health Equity, for example, and our Public Health Division. Next slide, please. So I just want to take a moment to read this outcome statement. Equity itself is embedded into policies, practices, and partnerships across the department to advance community-driven, culturally responsive, population-level health solutions that address the root cause of health inequities and improve health outcomes for all. To bring all of this together, we centered accountability on a community-centered key performance indicator, or KPI, and we are prioritizing a KPI that focuses on the number of health department initiatives that were co-designed or are co-designed with community partners. And selected this measure because it reflects, again, our commitment to culturally responsive, community-informed, or community-driven solutions that address the root causes of health inequities. And it also helps to bolster or further build trust in community, if you will, with respect to what we're trying to achieve collectively in partnership with community in the department. And doing so helps to ensure that our work is both grounded in lived experiences, again, helps to build that trust and leads to more effective solutions that are co-created in partnership with community that address health inequities at a population level. And so for 2027, our target is to have 6 to 8 initiatives that are co-developed or implemented through formal community partnerships and a co-design process. Next slide, please. Thank you. And as I mentioned earlier, we took a very disciplined approach to how we approached sort of the alignment of our resources with respect to both our current constraints and realities and future investment priorities. And as part of that process, we identified targeted reductions in select roles, including, as Trista mentioned a moment ago, a project manager, a manager 2, to address span of leadership, and also elimination of a long-standing legacy community health worker training program that has been around for roughly 20 years. These decisions reflect both internal priorities as well as external shifts. And the Office of Health Equity, just to sort of build on that comment, and as Trista mentioned too, just to kind of uplift this again, we'll transition from a sort of providing a more direct services, a direct service provision model by which we are offering this training to community, to a more focused sort of departmental technical assistance model that allows us to build the internal capacity together with also maintaining the coalition work and having that inform how we more effectively deliver our culturally specific and culturally responsive programs and services. And while this will be a loss with the department or for the department, it also represents a success story that I want to lift up at this moment. It shows that we have been sort of the prototype, if you will, or the example by which we can do this work in partnership. And it's been some work that has been proliferated and replicated by other agencies and institutions, and both at the across the state, quite frankly, and also in various ways, like there are currently CEU programs or other certification programs related to community health worker training. And so this success story, as I mentioned, is one of us training and capacitating and empowering other community partners and other agencies to take that training on, and also that service provision, if you will, in that direct way for community health worker training. And it is a workforce entry or a workforce development strategy as well. And like I mentioned too, the regional landscape in general for community health worker training has matured significantly, and those CEU and or certification programs are now more widely available through those community partners. This evolution allows us, as I mentioned, to refocus our limited resources differently. That's the shift I was referring to, and minimizing operational impacts while creating flexibility to invest in internal systemic support and accountability. That would include, for example, carrying out and or helping to guide implementation of our health equity plan for the department, as well as our county workforce equity strategic plan. And the CHW, as I'll just call it, so the Community Health Worker and Popular Education Program, they have both been legacy services since the early 2000s. And this great work can be seen across the county, and we will continue to use popular education methodology, and we do have a number of team members across the entire department and nested in our divisions who will be able to carry on that work and apply that methodology. And so while the Office of Health Equity might look a little different with respect to that provision of direct service. Where that's concerned, we will continue to focus on community mobilization and resource alignment, as well as internal capacity building, workforce equity benchmarks as outlined in our workforce equity strategic plan that we call affably the WESP, and also data-informed decision-making and policy transformation. So those are some of the ways in which we are making space, if you will, or creating ways in which we will be able to deliver services differently. And also, lastly, I guess with respect to the community health worker training program, that's also an example of where the health department has been a trailblazer in incubating the need for training and capacity building in the community. And when we started this work, we were among very few organizations doing this, and now there are dozens of organizations doing this training and capacity building work in the community. And we help seed that work, and so it gives us some solace, if you will, to know that that work is continuing in different ways, and it's more, again, broadly available. And so now I'll turn it over to our Deputy Director of Operations.
I just feel like if we go through all of this, it's going to be like hard to go.
Oh, sure. Absolutely.
So is this a good, I mean, I don't want to. Sure. Is this a good spot? Okay. Thank you, appreciate that. I hate the reductions, that's so hard. There's a couple of areas that I would like some follow-up. So I can also try to put this in writing. I am very curious when it comes to some of the direct services reductions, which ones of those reductions have we determined we could bill Medicaid for? And then I'm very curious about if we were to bill Medicaid aggressively, what would be the general fund still needed to operate those programs, and how long would it take to get to full billing capacity? And then I'm also curious about, I know that we lead with race when we talk about issues related to health equity or equity as a county, but I get nervous to not include other marginalized communities in which there is a known and significant health disparity, particularly disability and members of the LGBTQIA2S+ community, and the unique challenges of people who hold intersectional identities. And I particularly am interested in how we looked at the budget in relationship to the really intense attack on the trans community, particularly as it relates to access to healthcare and life-saving healthcare. I don't know if what we're doing reflects that, makes it worse, tries to compensate for some changes that are being made. But it would be really helpful if that data exists to be able to look at that. And then obviously, I don't know if the sample sizes are enough for intersectional identity, but I have a concern about that. And I'm also, as we look at the federal reductions, I would be very interested to have kind of an equity lens to see, because we've lost federal funds, some of which were targeted towards specific underserved communities, how do we weigh our reductions in light of those reductions? Thanks.
maybe just say, so somebody's happy to follow up, and the folks who are doing additional presentations throughout the day are also listening, and tomorrow and can incorporate some of that, I think, particularly in the intersectional identities piece and how we made decisions there with the trans community, our LGBTQ2I+ communities, and disability communities, so certainly there, and then heard the follow-ups for the equity lens on federal funding, which, yes, you're right, some of which was specifically focused in a culturally specific way from the feds, and then we also always look to do kind of equity-based work with our federal funding as well, so we can pull some of that out too. And the direct service and Medicaid question.
Before you jump into operations, I had one back on slide 29, significant reductions, or sorry, significant reallocations. What is the contract underspend? What is the color of money of those?
General fund. Was that the question?
Yes,
Yeah,
so that's all
county
general fund?
Yep.
And so was this underspend from this fiscal year?
Last fiscal year. We looked at the past 3 fiscal years, actually.
Okay, I'm sorry, I'm trying to follow the money. So it was underspend that was in last fiscal year that didn't go back to the general fund, it stayed in the health department? Or you projected reductions based on historic underspend?
So there's probably both, and Trista or Derek can correct me. We do give money back at the end of the year, so there is money that is, went back at the end of the year or was spent in the department.
Okay, I would love the specifics on that, and if it needs to be in follow-up, I don't know. Okay.
Sounds good.
Thank you.
Hi, I'm Derek Moden, Interim Director for Finance and Business Management. And as Rachel said, the monies that were underspent do go back to the central. It's just that we looked at contracts versus budget and saw that's where we gathered the underspends from.
Okay, so you reduced that in your budget this year and put those dollars into these other programs
Correct.
instead? Thank you.
All right, any other questions right now? Okay.
All right. Hello, everyone. My name is Valdez Bravo. Is he, him, his pronouns. I have the honor of serving as the Deputy Director of Operations at the Health Department. So, Chair, Commissioners, great to be with you this morning. I'm going to talk really quickly about the Operations Division, what we do. The Operations Division, this is going into our 4th budget year of existence. We were created in FY23 as the recognition that after COVID, there was a variety of supports needed for the health department staff doing all the hard work on the front lines, and we needed a little bit more infrastructure and operational support so that that problem solving and capacity didn't have to fall to supervisors and managers to get the job done. So when I describe operations to folks, or I describe what my role is to people out when I'm out and about, I say I'm kind of like a chief operating officer minus the financial stuff, minus the audits and contracting and budget. Because it's really the operations that makes the work go round. And when I come to work every day and my team in the operations division come to work, we basically are there to do 2 things. We're there to get barriers out of our staff's way so they can do the job that they need to do to deliver for the community, and to get them the resources they need to do that job in the way that our clients deserve. Next slide. This is really a snapshot of the operations division minus HR, which is currently, you'll see, budgeted in operations, but is moving more and more under kind of central oversight. But for the operations that I'm working with day in and day out, we've got continuity of operations planning, which is also known as COOP. This is providing essential coordination to safeguard the health of the public, particularly in the event of the loss of staff, systems, and facilities, by ensuring continuity and regulatory compliance. So when you're in your blue sky periods, or when nothing bad is happening, I don't know, it feels like it hasn't had that happen in a while. But when things are a little bit not in reactive mode, you're working with your programs to develop plans and policies and prioritize work and triage. So when you lose power, or you lose a site of care like a building, or something else happens that disrupts services, it takes the thinking out of the response. The staff can just launch into action mode, have their point of contacts, and go. And so we're really thankful for our COOP coordinator who does that work. And I've been told that we lead the way in the health department on COOP for the county. In terms of data governance and quality management, this is assuring that we have data quality, data fidelity, and data integrity, and promoting regulatory compliance. The health department, being that we are, working with the FQHCs, with behavioral health, public health, we have HIPAA-protected information. We have a higher bar of safeguarding and diligence that we need to do to make sure that our clients' information is protected, particularly in this era where that kind of information can be weaponized and used to target communities. In terms of facility safety and security, this is new in operations. It's not new to the health department. It traditionally has lived within finance and business management, but it was kind of recognized that it was more of an operational role. So I'm now working with our facility safety security coordinator who liaises with our workplace security team on contracted security personnel at our many sites of care, our 34 sites of care that Rachel mentioned, and safeguarding staff and clients, and then working with DCA and the facilities team to make sure that our buildings and leases and our footprint is managed, as well as working very closely with IT, which also dovetails with the, intersects with the data governance and DGQ unit. And then also, again, in terms of response and recovery, this, again, my position and our team was kind of born out of the post-COVID lessons learned. And so response and recovery really is coordinating functions in the event of emergency, large disease outbreaks, severe weather, other crisis situations, so that health is maintained and avoidable deaths are minimized. And one thing I'm really excited about is how in this budget we are proposing and adding an emergency manager to just really shore up the ability to do that. So working hand in hand with our COOP coordinator, our safety security liaison, responding to incidents that happen is going to just really prepare us to be provide as seamless service as possible when things happen that affect operations. So I just want to say that within the operations division, if you think about the countywide strategic plan, we really are aligning under focus area 4 of operational excellence. Okay, next slide. So as you can see here, our budget went up, so our budget goes down, but the FTE, sorry, the general fund goes up and the FTE go up. And really, that's not because the operations division, you saw we're like 2.4% of the health department budget. It's not because we grew significantly or we added a bunch of operations people. It really was kind of more of an accounting of the HR is living back in the operations divisions budgetarily. So that's really what that growth is recognized. The only real changes were that safety security specialist coming over and the addition of an emergency management position to add gaps in support. All right, next slide. One KPI that we wanted to spotlight really was related to our public records request. Again, with the Data Governance and Quality Unit, transparency and maintaining the public trust is of critical importance, in doing so in such a way that doesn't compromise or violate privacy laws and compromise client information. So really our outcome statement is, we have a documented assessment, a current state of maintenance, security, and structure of health department data and files to include the development of workflow improvements to reduce time and resources spent to maintain and remain in compliance with statutory requirements. So, our title is Public Record Requests Completed Within Statutory Deadlines. We get our FY26 is we're on track to do at least 96% of those completed within that required time frame, and the goal in FY27 is 99%. I would say that our public records professional is very good at her job and basically always at least acknowledges and gets an extension if needed, but usually we don't even need the extension. We're able to fulfill those, and it's a team sport, and she's the air traffic controller to make sure that happens in the way it needs to. All right, next slide. And then last slide for operations before I hand it off to my colleague Derek is just related to reductions. So last year, with the exception of learning and development, our HR team really was held harmless in the budget last year. And so as we looked at meeting constraint this year, the operations division did look inward to the human resources team. And this has resulted in 3 FTE reductions. One is our recruiting supervisor, who's done a phenomenal job in that role. And also, the good news there, the bittersweet news, is there's such great standard works that have been done through Kaizen and other lean events with our recruiting team, with how they do their recruiting work, with how they do the selection processes, and just managing their workload that although that position is being lost, I'm confident the quality of the work will maintain with our excellent recruiters. There is a loss of an ADA specialist, and we know some of those functions are being focused more on a shared services model. And then we also are losing a manager onboarding specialist who is a staff member who's really been at the elbow with managers to make sure that they have an excellent onboarding experience, but again, moreover, know how to provide an excellent onboarding experience to all the new staff, because we want to make sure that people have an awesome experience when they first arrive at the health department. They have the tools they need, the information they need, and they are empowered to do their job from day one, even though we don't expect them to be in their stride on day one. So that position is being, a lot of good work was also developed there. We have SOPs, we have standard work. We're developing an administrative community of practice that will take on that work, and we also will partner with our friends at Central who also provide those kind of supports. So with that, I'm going to hand it off to Derek to talk about FBM.
Good morning again. My name is Derek Moden. I am the interim director for finance and business management, and I lead currently a team of 58+ staff members who are committed to ensuring that the bills are paid in the health department. We are paying our communities, and we are ensuring that we are operating in compliance with all the FIN policies of the county. Next slide, please. From this slide, I'm breaking down FBM into really the 3 program offers, but and that covers the 3 major service areas, which is our contracts and procurements team, medical billing team, and our core accounting services. And from this slide, you see that in the next fiscal year, we plan to continue to deliver over 1,000+ contract action requests, which leads to over about 359 executed contracts. And with our purchase and procurement teams, procuring goods of around $67 million. Our next area of focus is our medical billing and receivables team, which processes about $80 million in annual revenues for our clinic, as well as they work with about 200 insurance carriers when they're processing and reconciling those claims. And then our third area of focus for finance and business management is our accounting services team. And within our accounting services team, we have AP, cash management, grants management, as well as financial reporting that we provide those services to both our divisions, the various divisions within the county health department. And these teams manages more than $350 million in revenues, which span more than 200 5-digit funds within our reporting structure. Additionally, our AP team currently processes more than 20,000 invoices each year. Next slide. In this slide is our year-over-year budget from FY26 to FY27. As you see, there's a reduction in our general fund, as well as a net reduction of 4.5 FTE. And what you see in the Fed State Fund is really a funding for the Rockwood improvements for our ICS. One of the things, ICS is enterprise fund, and they are not, we have to separate the general fund from enterprise fund, so there's a general fund matching component, and so that 1.5 million is just held in FBM. Next slide, please. The KPI that we are focusing on is ensuring that invoices that are due in full within 30 days are processed on time by our Health Department AP unit. And so what you're seeing in this slide is the number of invoices that we receive based on the number of invoices that are paid on time, as well as the net, looking at the net 30 and then processed on time. In this slide, one of the key findings that we have is that you see the majority of the invoices that the AP team is receiving and processing is the majority are received late. And so we process, when I say late, they can't be processed within the 30 days for which we are ensuring that we're getting timely payment to the vendor. But if you look in the green, those are the invoices that we receive on time, and the light blue kind of is the processing time. So we generally process the invoices that we receive on time within the 10 days so that the vendor can be paid on time. We put a 97% of total invoices simply because there are invoices that we receive that there's a lot of research that has to be done in order to process it. Next slide, please. One of the key challenges that we are experiencing in FBM is our accounting services capacity. And what we're looking at is doing continuous trainings throughout the various divisions to ensure that when we're receiving invoices or we are working with any of the county staff around business functions, around contracting, around any payments of anything, is that we are doing continuous trainings and improvements so that staff are aware of the FIN policies, the regulations, and so that we are looking to generate efficiencies so that would offset any of the decreases in accounting, the accounting capacity. Next slide, please. These are the reductions that we're experiencing in FBM. And so in program offer 40040, Finance and Business Services, we're looking at one FT impact, and that FT impact is our cash management supervisor, as well as some internal supplies that was, I should back up, internal supplies as well as during previous budget years, our medical malpractice insurance was budgeted in FBM. Now there's a different model where medical malpractice insurance is spread through internal services. So we reduced that. That was about $77,000 that we reduced out of our budget. And then looking at our contracts and procurement teams, there's 2 FTE reductions that are proposed. That's one is procurement specialist senior, as well as a contracts supervisor that we are reducing in that area. Next slide.
That's actually these slides.
Somehow transitioned over to sort of the centralized shared services?
No, that position will not be.
Okay. Yeah.
So any other questions on this? We do have corrections. Health are also scheduled for this morning, so we can do some corrections on, or questions on anything we've heard now, and then we can move on.
So just a question, the financial and business management seems to be where there's the lowest span of control, and I was just hoping somebody could speak a little bit to the why of that. It looks like it's like a 4, hovering between 4 and 5.
I'll say one thing, and then Derek, if you wanted to chime in on the why. I mean, there is, this is an area where we have reduced supervision in a number of positions to address and acknowledge that it does have a low span. And then, I mean, I think the why in some ways, and, please chime in, is, and these are working managers as well, but we do acknowledge that that's an area where we need to be looking at a different model that has a higher span, and have done some of that work in this budget. And I know I've had conversations with Eric in the shared services area as well, just acknowledging that it'll be a continued issue.
And part of the why is just the function of the different like AP, you have a different skill set than your grants management teams, as well as your cash management teams. Part of those were, legacy staffing, and so we are trying to address the span of control issues with this current budget. There was a reduction, I think, of 2 managers within that span of control during this budget cycle.
Thank you. And to be clear, some of your other divisions have ridiculous spans of control of like 20-something. So it's across the department, clearly balanced. Just wanted to dig into that one a little bit.
Okay, any other questions for these folks before we move to Corrections Health? All right, thank you all very much for a really thorough overview of the Director's Office, operations, and the department itself.
Yeah. He's like, I'm out.
Thank you. It's good to be back. I'm not sure if it's just the next slide, Tasia, or?
It's a new presentation.
Is it, new presentation, okay. All right, well, I'll go ahead and start with my introduction while the first slide loads. Hello, everyone, again. For the record, my name is Valdez Bravo. Use he, him, his pronouns. And I have the honor of serving as the Deputy Director of Operations at the Health Department, but I'm also serving as the role of Interim Director of Corrections Health. And I am joined by my colleague, who will introduce himself.
Well, I was going to say good morning, Madam Chair. Oh, thank you. But she stepped away. So good morning, board, members of the board. For the record, my name is Tony Gaines. My pronouns are he, him, his. I serve as the Director of Operations and Corrections Health of the Health Department. And today, we will be providing you with a high-level overview of Corrections Health Division and walking you through the process we use for formulating our FY27 budget. And I'll pass it back to Valdez.
All right, thank you. And I'll just wait till, there we go. All right, thanks, Tasia. All right, we can go to the next slide, Tasia. Oops. All right, great. And then next slide. All right, perfect. So, it's great to be here with you all today to talk about the Corrections Health work. The Corrections Health Division of the Multnomah County Health Department is responsible for providing constitutionally mandated services to adults and youth in custody at the 3 carceral settings operated by the Multnomah County Sheriff's Office. These 3 sites consist of the Justice Center, also known as the Multnomah County Downtown Detention Center, or MCDC, the Inverness Jail, and, as you'll see referenced as MCIJ, and the Donald E. Long Juvenile Detention Home, sometimes referred to as JDH. Of note, this does not include the Columbia River Correctional Institution, known as CRCI. I point that out because sometimes in the grand jury reports you'll see recommendations about them, but that is not under the span of our care. All booking and release of adults in custody occurs at the downtown detention facility, which is a supermax jail and features single-cell units, including an acute mental health unit. The Inverness Jail features more of a dorm setting with limited single cells and is where the majority of adults in custody are housed. The Donald E. Long Juvenile Detention Home can currently house up to 25 youth at a time. Corrections Health works in partnership with the Multnomah County Sheriff's Office, also known as MCSO, to deliver care within these carceral settings. We are embedded in the facilities to provide medical, dental, and mental health services, and we also provide complex medical support to patients who require emergent care or other specialized care that is outside the capability of our Corrections Health teams. Tony will now provide a closer look at how this care is delivered.
Okay, next slide. So as you can see on the screen, Corrections Health provides access to timely, effective, equitable, and patient-centered care for more than 17,000 adults and youth in our custody. On any given day, we are responsible for the care of up to 1,000 adults and youth in custody. We maintain service levels that support mental health, mitigate suicidality, and provide ongoing care for those with acute health care needs. We recognize the social determinants of health and the impact of lack of health care can have on exacerbating health conditions and increasing acuity. We are often caring for people who have gone without health care. One thing that is important to know, and most in this room already know, is that we know that Black and brown communities are overrepresented in the criminal legal system. Therefore, as we think through this budget and how it delivers, it should be understood that all Corrections Health investments for care received during incarceration and through our release and reentry back into the community are targeted investments that serve historically marginalized communities. In addition to our physical, mental, and dental health care services, we are working to reduce overdose and withdrawal effects through multi-pronged medication-supported recovery, or MSR, for people who enter custody experiencing opioid addiction. The standards we apply to care that we provide are in line with National Commission on Correctional Health Care, or NCCHC, and we last received accreditation in 2025 with that 1,000 accreditation score at our 2 adult facilities. Although our next accreditation visit is in 2027, we remain in constant preparation for accreditation and compliance and adherence to NCCHC standards. Next slide. The next slide talks about our operating budget and our FTE. And in this slide, I would like to talk about the changes in our budget from a high level. So quickly going through here, Corrections Health has worked in conjunction with Finance Business Management to not only identify ways to drive down costs, but also highlight areas in which we can accurately account for and define our operational costs, as well as explore opportunities for cost savings while simultaneously prioritizing our desire to not sacrifice patient care. To illustrate a few of these budgetary changes, I would like to start by taking a moment to explain why our FTE went down, although the overall budget increased. So in regards to the FTE reduction, even after increasing the budget to accurately cover these high operating costs, we still faced a deficit. To balance the budget, we were required to make difficult decisions to reduce and reallocate FTE. And this is what is represented here in the 11.1% decrease in FTE from FY26 to FY27. This reduction included positions across the division, such as behavioral health, and significant reallocations within the Transition Services Program, or TSP, to ensure we could sustain funding for high-cost drivers like outside medical care. Even with the increase in funding, we did not have enough funding to balance the budget, which led to a reduction in FTE. So for example, in the fiscal year FY26, we were already projecting to overspend the professional service budget for outside medical costs and pharmaceuticals, which have been rising year over year. However, as I mentioned earlier, we have worked with FBM to ensure our FY27 budget now incorporates these essential costs going forward. Next slide.
As Tony mentioned, healthcare costs have been rising, and the medical inflation rate is known to rise at a higher rate than that of non-medical inflation. Again, the key cost drivers in the Corrections Health budget can be attributed to outside medical care, which is anytime we send an adult or youth in custody out for care to a local healthcare system, and due to pharmaceuticals. And just to put a finer point on that, when we looked at the data and when we looked at our past spending, the average ED visit of one of our visits of sending our adults or youth in custody out has doubled since 2018. So in just 8 years, the average cost of those visits doubled. That's just representative of the type of increasing costs that we're facing with our outside medical care. I want to reiterate that outside medical visits and prescriptions, the medicine, are part of our constitutionally required care. A little later on, we will talk about some of the internal strategies we're using to mitigate these costs in ways that do not compromise that care. In past budget years, we relied more heavily on staffing agencies to fill certain clinical positions and to pay for overtime in support of our 24/7, 365 operations. I'm happy to report that our reliance has diminished greatly in the past 2 years, and although we allocated a portion of the budget for these types of staffing costs, we are nearing full staffing for our nurses and our providers. Our remaining focus is on our mental health vacancies. It should be noted that although the majority of our gains in terms of staffing are due to aggressive and successful recruiting efforts, we also eliminated long-term vacancies in order to reallocate funding to our outside medical and pharmaceutical budgets. Next slide. So as you can see, the main budgetary challenge we face going into FY27 was the risk of overspending due to those growing costs of healthcare. We applied a multi-layered strategy in order to address high rising costs and inflation. Our approach began with looking at the chair's budget priorities, as well as the health department's budget priorities and budget rubric. We then reviewed the list of existing vacancies and worked with individual managers and supervisors of the various programs to identify 1 to 2 positions in each program that could be offered up. We sought to prioritize vacant positions over filled positions. We strived to strike a balance of non-direct services and direct services. We also sought a mix of management staff and represented positions. And what's more, we also took span of leadership or span of control into account due to county HR's direction to evaluate positions that had a low number of direct reports. But at the end of this process, the Corrections Health Division was still unable to cover the anticipated costs of outside medical and pharmaceutical costs based on forecasts derived from the past 3 years of actuals. So this only left one option, which was to propose elimination of a whole program, the Transition Services Program. Next slide. Of all the programs in Corrections Health, the TSP program, Transition Services, was identified as the only non-constitutionally required service. The FY27 budget rubric prioritized statutorily required unique governmental services. And although the TSP is unique in many ways for what it does, again, it was the one aspect of our care and budget that we are not constitutionally required to do. However, with funding provided in the executive budget and the provided investments allow us to continue basic support of adults in custody who are exiting, preparing for reentry. These basic supports include, but are not limited to, Medicaid enrollment and reinstatement, care coordination, and the distribution of life-saving naloxone and basic hygiene supplies. Tony will now present a picture of what services can be delivered by TSP in the existing iteration of the FY27 Corrections Health budget. Next slide.
So as Valdez mentioned, this slide will give an indication of how TSP will look in fiscal year 27. This slide that we're looking at now illustrates the Transition Services Program in FY27. We're thankful to the chairs for the chair's proposed budget partially restored 5 FTE to the program, including the TSP supervisor, an OA senior, and 3 community health specialists. Additionally, the program maintains core functions focused on 3 areas of critical post-release support, and they are basic needs, which is providing essential items like clothing, shoes, food boxes, immediate needs, and hygiene kits. As you all know, throughout the year, we experience extreme weather. So our TSP folks are responsible, and they do a great job of making sure people have the appropriate gear and appropriate clothes for that particular season. There's also our TSP team will still provide economic stability, which is assisting with resource attainment, such as SNAP cards, SSI applications, and helping folks with expungement for their record. Also, community integration, offering information for shelter locations, rental assistance, and tattoo removal assistance. I want to take a moment and talk about the loss, though, of case management or our transition planners. This is definitely a key component of TSP and a key role that helps in a lot of different ways, and I'll mention some of those ways here as well. In spite of the partial restoration, which again, we're definitely thankful for, the program will lack the high-level case management and case assessment functions due to the elimination of the transition planners, which are clinical support specialists. This means a significant loss of the systemic coordination that bridges courts, attorneys, and community providers. The impact of that loss, from a data perspective, is that the transition planners, they play a major part in recidivism. Our data shows that clients who complete a transition plan with one of our transition planners had a return to custody rate of 16%, significantly lower than the county average of 23%. So losing this critical function is expected to result in the following. There will be likely court system impacts, which will result in delays or uninformed court decisions for justice-involved individuals, potentially leading to increased reliance on high-cost systems like OSH or the Oregon State Hospital. There are some community and public safety implications as well, specifically an increase in homelessness as people are released back into the community, a greater utilization of emergency rooms and crisis systems, and higher rates of recidivism as individuals lose stability and connection to services upon release. Next slide, please.
Sorry, before we jump to the next slide, what program offer or offers is the TSP in?
40047.
Yep.
Thank you.
All right, next slide. So next, we're going to look at the different reductions. So this first set of reductions was for to meet constraint for our 7% target. This reduction results in impacts of our corrections health mental health manager role position, which is a filled position, 2 mental health consultants, which were vacant positions, and a vacant psychiatrist position. The mental health consultants in corrections health will continue to be supervised by 2 mental health supervisors, one overseeing MCDC and the other overseeing the Inverness Jail and Juvenile Detention Home MHCs. But these supervisors under this new model will report to our medical director, Dr. Stephen Kane. Corrections Health is exploring a new staffing structure that should more evenly distribute coverage and access for adults in custody, which will mitigate the loss of the 2 mental health consultants. Additionally, our psychiatric mental health nurse practitioners, or PMHNPs, will continue to provide a higher level of mental health acuity and prescribing knowledge of mental health medications, and corrections health plans on partnering with the Behavioral Health Division and other system partners to address our needs. Next slide. So as you can see from this slide, the impacts were distributed across the various corrections health programs. The only program offer or service that did not take a reduction was our dental program, due to this program consisting of 2 staff, our Rockstar dentist and his Rockstar dental assistant. But this budget will result in reductions for reallocation of 2 vacant nurse positions and a vacant OA2 position at the Inverness Jail, a vacant nurse position at the Downtown Detention Center, and a vacant nurse position at the Donald E. Long Juvenile Detention Home. These positions were part of an experimental nurse overstaffing model that several years ago originally added 14 positions above and beyond what we needed for our staffing model. Now in FY26, we already reallocated 5 of those not yet filled vacant positions to cover our MSR investments when we hired our half-time addiction medicine provider and added 6 LPNs to help with expanded Suboxone administration. So those had been an unbudgeted decision during the fentanyl crisis. Well, we're still in the fentanyl crisis, but during that overdose prevention response plan. But then to sustain those, we had reallocated 5 nurse vacant positions, FTE, to pay for those staff. So in this budget year, we are again reallocating not yet filled still vacant positions to cover our structural budget adjustments. However, we're happy to report that we only currently have 2 RN vacancies that lack an inbound candidate with a start date. So we're really excited about that and really thankful for the tenacity and aggressive recruiting and being out in the public of our Director of Nursing, Lori Della-Scott. And it's a team sport, and we have phenomenal recruiters. In addition, 5 positions are eliminated in our TSP program. The filled TSP manager position, a filled community health worker position, and 3 clinical support specialist positions that Tony mentioned, also known as TSP planners. The team will be supervised by the remaining TSP supervisor, and the work will be drawn down to basic levels, as Tony mentioned on the earlier slide. The TSP supervisor position was preserved over the TSP manager position due to span of leadership considerations. As in the future budget, the clinical personnel, although still budgeted in the TSP program in FY27, will be realigned under clinical supervisors in the other program offers. Lastly, the FY27 budget will see reductions in our operations program offer, including a filled operations supervisor position, a vacant certified medical assistant position, and the vacant corrections health division director position that I now fill. The operations supervisor predominantly worked at and supported the MCDC office assistants, but also provided support to the entire division, primarily related to pre-hire and onboarding tasks, including but not limited to background clearances. This work will be absorbed by the remaining operations supervisor, whose amount of direct reports will now double and who will now alternate between MCDC and MCIJ. The certified medical assistant previously helped with quality and compliance, and this work will be absorbed by the remainder of the quality team. In FY27, the Corrections Health Division will be led by a triad model, where the operations director, our director of nursing, and our medical director share responsibility equally for leading the organization on a day-to-day basis, reporting up to myself as the Deputy Director of Operations position at the Health Department. Next slide. This slide, slide 60, represents the cost and FTE total of the positions that the Corrections Health Division either reduced or reallocated in our FY27 budget and program offers. As you can see, roughly 3.5 million was reallocated to cover corrections health known or forecasted positions. So again, although we are talking about a lot of vacant positions and other filled positions being eliminated, it wasn't going outside the department, it was staying within the department and there to help cover those rising costs of pharmaceutical and outside medical that I've been mentioning. Next slide. Again, the Corrections Health Division thanks the chair for her investment of 5 FTE to help ensure the most basic TSP services continue in FY27. This will help further our mission of Corrections Health on behalf of the thousands of adults and youth in custody we serve each year, and in doing so, will benefit the greater community. And I'm going to hand it back to Tony.
So throughout our presentation, we've obviously been talking about FTE and budget, and so now we'll shift gears just a little bit, talk about our KPIs. Next slide. As you can see, this slide focuses on our outcome statement. It highlights our 2 most critical public health priorities in FY27, suicide prevention and overdose prevention. Our overall goal, which is a joint effort between Corrections Health and Multnomah County Sheriff's Office, is to maintain 0 suicide deaths and overdose fatalities in the jail. Specifically as it relates to suicide prevention, we have embarked on a couple of initiatives. Our mental health leadership has successfully implemented safer suicide care. This is a national evidence-based model to support education and suicide prevention efforts. This initiative includes data collection, education for all staff, including our Sheriff's Office partners, research and efforts to align policies. A key metric is our commitment to increasing support and treatment for individuals in custody experiencing suicide ideation or history of attempts. We are achieving this through the further implementation of the Columbia Severity Suicide Risk Scale, or CSSRS evaluation. So that really encapsulates the work that's been done as far as our efforts to prevent suicides again in the jails. The other component for this outcome statement, though, is overdeath prevention. So some of our initiatives here are we're targeting a reduction in the number of overdose incidents within our jails by again, partnering with MCSO, which is another, we have one of those blossoming relationships that we've put a lot of equity and sweat equity and some good conversations trying to align our policies, get on the same page, kind of have a shared approach and methodology to specifically overdose prevention and suicide prevention as well. But this is supported by our work to ensure individuals experiencing opioid addiction have reduced overdoses and the withdrawal effects that also come with potential with overdosing by receiving medication-supported recovery and/or methadone treatment. We are also continuing to work on the Adults in Custody Mapping Project to better understand and address any risks that exist. Next slide, please. So the opportunities. This slide focuses on cost avoidance and management. This slide highlights the key opportunities for our cost management as we look to contain the costs and achieve financial stability while maintaining high-quality care, as we've mentioned before. Our 340B drug pricing program, this will be a huge opportunity for us. Recently, Corrections Health successfully submitted our application for the federal 340B drug pricing program. A little bit about this program. It allows us to purchase certain outpatient medications at a significantly reduced cost. The initial focus of our efforts is on expensive public health-driven medications for HIV and Hep C. And over time, these savings could potentially exceed well over $500,000 annually, with expansion to additional drug categories, which can be reinvested to expand access and continuity of care. So it's definitely something we're excited about. Thanks in large part to Dr. Stephen Kane and our provider team, we are actively exploring the benefits of utilization management review of outside medical, which we've mentioned before as well. We have established a utilization management process and a pharmacy and therapeutics, or P&T review, to learn and contain the rising costs of outside medical care and our pharmaceuticals. So it's another huge initiative that we're excited about. Also, in addition to other cost-saving measures that we embark on, are partnering with CHP, which short for Correctional Health Partners, to aid in patient care coordination, and they work on behalf of our team to aggressively negotiate contracts with an emphasis on reducing costs with healthcare providers in the community. And lastly for this, achieving operational excellence through the quality team. Our quality team is small but mighty. They do a lot of great work, and our goal for them this year is to really leverage their work to improve outcomes and efficiency by using data and our accreditation standards to ensure that we are actively and effectively demonstrating our commitment to high standards of care. All right. At this point, I want to thank you for the opportunity to present to you all. This concludes our actual presentation, and we're available for any questions that you may have.
And Chair, before you say, just want to say, our Corrections Health team has grown and done so much in the past few years. We're really proud of that 100% accreditation from NCCHC that we received last year. Exciting to see the staffing levels coming together after all these years of grappling with that issue. And we are thankful for the support and look forward to your questions.
Yeah. Thank you. Just opening it up for anyone who has some questions for Corrections Health.
I just want to confirm the vacancies that you talk about using as reallocation, those show up in the previous presentation in the appendix. There's all the vacancies, all of those have been reconciled. I don't want to have to go back and do all the math. They're all reconciled? Okay, thank you. And then my question's just broadly, and this can come as follow-up. You talked about the case management work for transition. I'd love to understand more detail, concrete of what they do. And part of what I'm getting at is trying to understand, as we're having these reductions, where there are opportunities for collaboration and partnership across departments that are serving this same population. I know the sheriff has been talking about having some transition services at the first floor of the jail. There's opportunities for community-based organizations to provide services there. So understanding what might be lost, and that will help us see if there's opportunity for some different collaboration and somebody else to kind of help pick up some of the work. And then I would just love to know more broadly if there's specific things that you're envisioning on for TSP and how it coordinates with the jail staff and some of the work that, we should all know Steve's job title by now. But I'll just say Steve Cicatelli and whatever his job title is. And what the work that they're going to do there would be really helpful.
I call him the wizard.
And thank you for pointing that out. We'll definitely follow up with that information, Commissioner Singleton. One thing I neglected to mention is that when you look at the countywide strategic plan, focus area 2 on community public safety, that's where we really see ourselves and our corrections health budget and investments showing up. And one of the call outs for those measures and metrics is case assessments. So that is something that we can definitely speak to.
That's awesome. And I just have one other, random question, and we might have talked about this when we were doing a site visit, so apologies if it's duplicative. You all are doing really amazing work around injectables for addictions. Are you also able to utilize injectables for some of the psychotropic medications? And if so, I've just found so much success with the population of folks sleeping outside with that versus having to manage meds all the time, but wanting to understand the opportunity to do that in the facility, but also then link to services when they're back out in the community.
Dr. Kane is smiling.
Yeah, we'll definitely get you the full answer from Dr. Kane, our medical expert, but I can say that we do offer and have the ability to offer long-acting injectables for antipsychotic medications, and part of the important work with the P&T committee is like looking at those, making sure that we're selecting the ones that have the best clinical outcomes, while obviously looking at the very variables related to pricing and whatnot too. But yes.
Thank you.
Related to that, I know that we do have individuals who leave and return to us from the Oregon State Hospital. Are we still able to maintain whatever prescription combination that they have been successful on?
The short answer is yes, Commissioner Moyer. I would say that one of the barriers that does happen is that when someone is released from the Oregon State Hospital, we do get a report on their care and what they're the full picture view, but sometimes it's delayed in when we receive it, and they are working on doing some PDSA type measures to get it, but they don't have Epic, which is a big barrier. They don't have Epic at the OSH, so we can't see into their system and that care, so we're kind of reliant on paper packets and whatnot. Dr. Kane can speak to it more, but I really am thankful is that under Dr. Kane's leadership, he did orchestrate a visit to the OSH, and so a number of us went down there, met with their care team, talked about their transitions, but that's a long way of saying that yes, once we have that full picture of the medications, and that work does happen, usually by phone call from their facility to our lead nurse, we can maintain and continue those medications.
So it even have clinical notes?
Dr. Kane can speak to it more, but I believe they do come with a packet of notes.
Jesus. Cool. We have Epic though, right?
Yes.
Okay.
Just to clarify, excellent question.
State your name for the record.
Okay, Stephen Kane, pronouns he, him, medical director here at Corrections Health. Just to clarify, I think Valdez hit it right on the nail. Usually when folks are coming back from OSH, our nurses are calling over, trying to get the MAR and make sure that we have the appropriate medications for them. Sometimes it's a little complicated if there's medications that are changing or tapers or things like that. The actual clinical notes might not come for weeks after, and the person might not even be in our custody at that point, which can be frustrating.
Yeah.
But sometimes there is that, over-the-phone conversation around the clinical care at that moment. Yeah.
How many people decompensate in our jail that come back from OSH? I don't know if that's something that we closely track, but I worry about that.
Yeah, we can definitely look to see what data we do have to support that question and get back to you for sure.
Okay. I have another question that relates to the coordination between corrections staff and corrections health staff, and that has to do with how we handle ADA accommodation requests. My understanding is that it typically ends up coming through, what's the form that everyone can fill out?
MRF, medical
Yeah,
request
the
form.
MRF. What is the process of of coordinating and evaluating an ADA accommodation request, since apparently it's coming to you guys first?
I do know that we have the ability to honor those ADA requests because we just had a recent discussion about a better form of wheelchair for the setting, just based on unique carceral requirements. So they definitely come in, we have them. We know wheelchairs aren't the only thing that we're talking about here, but yeah, it would start with the MRF and then it would go up, and we'd probably have to get back to you on what that full evaluation process and if that process is owned by the corrections side or corrections health side. But everything we do, I'm really thankful that a lot of the work Tony has done in the past 2 years with this interagency collaboration. Tony's kind of been our champion leading the work with MCSO and Jenny Carver and the MCSO side. And so that definitely is a partnership, and there is shared decision-making when it comes to that because we both share the care of our folks in custody.
Yeah, it's definitely a collaborative venture where we do work with the different OICs at the sites, the facility commanders to figure out what is possible, what the implications are, all those different things. Because that definitely, MCSO rightfully cares about the security and the safety of the jails. So we take all those things in consideration and we work with them. Also, just for clarity, it is definitely a different process sometimes as it relates to staff with accommodations, obviously, than it is adults in custody with an accommodation request.
Yeah, I ask this because I have heard complaints and a lack of consistency in the process, as well as a lack of understanding of what is or is not reasonable, of which I do understand that this setting has unique issues, but some disabilities are not medical. Some disabilities are medical or have components of that. And I'm just curious, I'd love to see like just kind of a flow and to make sure that there is somebody in that process with expertise on the legal requirements of ADA to make sure that we are in compliance. Would be great. For corrections health staff, what behavioral health training is standard for any staff that works directly with people in our custody?
I could get you a full list of the gamut of the competencies, proficiencies, standard workday onboarding, so we can definitely get that. One thing I would say that in addition to we're taking more of a shared approach where mental health and suicide prevention in particular are not just the job of our mental behavioral health specialists, it's everyone's job, including deputies, including chaplains. And that's some of the work that we're continuing to do ongoing. One thing, Tony touched on it, but one thing I'm really excited about is that we've adopted the CSSRS, the Columbia Suicide Severity Risk Scale. I came from the VA. That was standard in primary care. We always did the CSSRS. It was just part of the visit, and now that's becoming part and parcel of all of our interactions, whether you're a nurse or an MHC or a provider. So that's something that's more general, but in terms of the specific training, we can get you a list. Tony, do you want to add?
Do you know if LEAP training is part of that training? LEAP, LEAP?
I do not know.
Okay.
Yeah, I'm familiar with that on the ICS side because I've heard of that, but not so much in corrections health.
Okay. It is a recommended training for corrections and corrections health, but I'd love to talk about that. And then to what degree does corrections health work with our corrections officers as to the appropriate level of, I guess I'll just be blunt because I can't think of a nice way of saying this. This really isn't meant to be unkind, but as somebody who has worked related to issues of care for people with severe persistent mental illness, I am very concerned about how our jail handles that population, and that it seems that we isolate and have less time out of cell for that population than we do for our general population, which is, I do understand that there are unique challenges to people who may be actively experiencing symptoms of severe mental illness, but it is clearly counter to best practice to isolate people in tiny cells for 23 hours a day who are experiencing like that is. So I do know that there's this very difficult balance that has to be thought through, but to what degree are our mental health professionals collaboratively working with correction staff on how best to manage particularly units that are dedicated to people experiencing mental illness? I have a lot of concerns about that.
Thanks, Commissioner Moyer. We can definitely give you kind of a fuller fleshed out answer. I would say just from the start though, like to take like a macro, meso, micro approach to it. Macro, we're thankful for the investments you all make in corrections funding for deputies, because when they have the deputies and the sufficient staffing levels they need, that results in more walk time for everybody. We see that, we know that has good health outcomes and bodes well for us. But again, to your point, with some of those folks that are in more of that acute mental health setting, 4D down at the detention center and our behavioral health dorm over at IJ, that can have implications for their walk time and ability to, and mental health acuity should not be, obviously seen as like a punitive measure or something that, could further degrade your mental health. In that case, we do have something called a multidisciplinary team, or MDT, which is a come together regularly, weekly, of our mental health consultants and deputies that come together. Really excited about the partnership of MCSO, and they have a mental health sergeant, and they have a team that have that specific training in de-escalation and recognizing signs and symptoms, and more they are at the table when we're doing our process improvement related to everything related to like suicide prevention and suicide. So the MDT is a place where that happens. And then on the micro level, I have heard, there's a lot of work to do, but I have heard great stories recently where somebody was having a behavioral health issue and the deputy did some questioning and realized it was due to a dental issue that was causing the person great pain and causing the distress, and we were able to get them dental. But there are also ways of recognizing behavior, like this is a behavioral health issue, this is not a behavior issue, which are very different, but sometimes can be blurred lines. So we can get you more information on that, but Tony, do you have anything you want to add in the moment?
Yeah, in addition to what Valdez says, I think there's just a couple things. Obviously, there's operational concerns, with a lot of our acute patients being on 4D and just the structural setup of that floor as far as having space and room to be able to be out of their housing unit. So I think that that's definitely a unique thing. So essentially, the detention center probably isn't the best equipped from a structural standpoint to be able to support those that need to be out of their cells more than they are in. And additionally, I think also recently we've been working with the Sheriff's Office to understand how they are, how they are experiencing basically capacity issues. So they're getting up to a point where it's 95% capacity, or really not high capacity, 90%, and that does stretch them very thin to be able to have adequate staffing, to be able to make sure folks are safe, make sure staff is safe, make sure people are in the right housing units, and also just ensure I guess, kind of a sense of safety and security in the jails altogether. So I think that does add a bit of a strain on the system internally, because it makes it so resources are spread thin to be able to meet the needs of those who, with SPMI, that probably should be out and being able to be out of their cells a little bit more.
And I just wanted to add kudos to our mental health team, our mental health supervisors. There's mental health first aid training that they went to and have brought back to and that extends to the deputy side as well. And then Dr. Kane has also stood up a 4D work group where they're doing really good, important work, doing kind of a fishbone of all the different issues that are happening. What is the purpose of 4D? Why is the classification? What is the diagnosis? What are the treatments? What are the barriers? What are the wraparounds? What are the supports we need? And that's where the partnership of a psychiatrist outside might be injected into that decision-making and planning. So we can get you more information on that as well.
One last thing I'd like to say about that is just with the psychiatrist, it's definitely been a position that is counted as a long-term vacancy. It's one that we've definitely had challenges filling for various reasons. But to Valdez's point, that would be another resource that would be very helpful to have to address that particular issue that you're raising, Commissioner Moore.
That's like community-wide.
Yeah. Oh, yeah.
One of the things maybe I'll just add about that to and Valdez alluded to it earlier in terms of working with behavioral health. So one of the positions that we have in the behavioral health budget is a behavioral health officer that would be working countywide, department-wide as well, supporting a psychiatrist, supporting corrections health, and being able to provide some services. So we're hopeful that that's a way to kind of recruit. So someone's that's not their only job, is because it was difficult to find someone that wanted to do that full-time, but it's a piece of what they would be doing, as well as then supporting other settings where folks are coming in for services, maybe not for their behavioral health services, but for services that then are other places, whether that's libraries or shelters or other things, and providing support in technical assistance and policy, and then also convening system partners in the behavioral health system, looking at gaps, using the assessment and epidemiology capacity, and answering some of the questions that you all ask us, right, in terms of what's the dynamic need, where are some of the gaps. So really using that model to help support behavioral health, both in the department, in the county, and ultimately in the community.
I'm very excited for this position. Yeah, so, yeah.
Good luck. I think my last question, I do know that we have reduced the number of deaths in custody, which is good. I know that we'd love to be at 0. But of the deaths in custody, how many have were individuals that were had a behavioral health related issue?
We can definitely circle back to you a precise number, but I would say, as I think alluded to on an earlier slide, something on the order of 65% of the folks coming through our doors have a mental or behavioral health diagnosis, grappling with SUDs and other functions. So we can definitely get that information to you. Anecdotally, I would say that likely the odds are high that they had some kind of diagnosis.
Thank you.
I have a couple of questions. And this is more from a historical standpoint, and I don't actually need it, the information right here, because I don't expect you to have it at your fingertips. But since I joined the commission, there has been a lot of turnover. And I'm wondering if you can provide just your sort of current retention levels from, in like broad categories from the top to sort of line staff. That would be helpful to see. I know that was just an initial challenge. Then I had a question about the vacant nurses, the long-term vacancies for the nurses' positions that have been eliminated. So just so I understand, because it sounded like you're reallocating that money to some other places, but it also seemed in your presentation that you were implying that that sort of gap that you have will be filled by agency staffing. So is it the savings from eliminating those positions going to both of those things, or?
Good question, Commissioner Brim-Edwards. So basically, we had added 19 nurse positions, or 14.3 FTE about 3 years ago for this overstaffing model, which is something that King County tried and seemed to work for them. We were never able to, the idea was that because turnover was so high, you had to staff up to here just to have what you need, right? It never really bore out where we added those positions, but we still saw the overtime and the mandates and everything not going down. So partially what we're doing this year is we still have a partial number of overstaffed vacancies, a smaller number, available to accommodate that margin. Some of the positions, the 4 RN positions, were allocated for the first time to have professional services contracted agency staff, but a much lower number than we've been using in the past, because we used to have agency PMHNPs and agency providers and agency nurses and agency MHCs and agency LPNs. Our reliance on those agency staff has diminished. And again, we always want to have in county staff first, but that was just simply a means to an end to meet our 24/7, 365 need. To your point, we now will have a small budget for some unexpected need. You're always going to have unexpected needs related to the nurses and MHCs and LPNs. We have several nurse vacancies that are still out there to have a little bit of an overstaffing margin. And again, just super thankful that if you look at all the hiring that's been happening and our vacancies, there's only 2 that are truly do not have an inbound person, and we have interviews scheduled every week. So we're really excited about that.
Okay, great. Then this is a question about the medication-supported recovery.
Yeah.
So when adults in custody are released from custody, what sort of tracking or handoff, or do you have any data on whether when people leave, we have no idea what happens, or whether they actually transition to some other form of care, or still, having access to medication-supported recovery?
Probably ask Tony to take on this one. We can definitely get you a good fuller answer from the experts, our TSP team and clinicians. But I knew that Tony spearheaded some work that intersected with that.
Yeah, I think there's a couple things with this. So this is definitely where the transition planners come into play. They help a great deal with that, coordinating those services, those warm handoffs to other agencies in the community. We've been working with, again, Integrated Clinical Services, ICS, around the Transitions of Services project, where those who are exiting custody, we work with ICS to try to get them engaged in one of our FQHCs, one of our community clinics, to continue their care, especially if they're substance use disorder, if it's something that they are dealing with. So those are some of the 2 things that are sticking out for me, that are efforts that we are working on, diligently working on. But the transition planner, I mean, that team, that particular role is really important to how we do that. But also our nurses play a great role. We have a nurse, we have a few nurses that work, again, with the transition part of trying to find other resources in the community to hand people off to that are suffering from substance use disorder.
The thing that's really exciting is now we have Brixadi and Sublocade, so we can do these 30-day long-acting injectables at release that really bridge that gap between that most vulnerable time of overdose and fatal overdose until they get into care. But to your point, we can get you information on, do we know what that looks like after 30 days? Is there continuation?
Yeah, that'd be great, because I'm interested in, in addition to the warm handoff, which sounds really important, but also, do we know, after that warm handoff, does it continue? It'd just be an interesting item. And then the other question I have, and this is just a general question about looking through the program offers and the performance measures. The performance measures appear to be focused on number of referrals, how many, let's see, how many applications for Oregon Health Plan have been submitted. Do you actually track, it's just not in the program offers, sort of the condition of the health of the people who are in custody? Because it doesn't seem to be in the program offer metrics. So I'm curious about that.
Great question, thanks. Yes, we have a robust, a small but mighty quality team led by Dr. Tim Victorella, who reports up with Tony in operations. But yes, we do have quality measures. They actually created, one of our staff went back to school, got an MPH, created this great dashboard that has, the quality metrics and measures of health outcomes, much like you would assess in a primary care clinic with HEDIS measures or something. So we have a variety of quality measures that we adhere to that are aligned with NCCH standards and that they look at, but we can tell you more about that. I know that our budget typically has been more of a production model in terms of the metrics, to your point, and we can circle back with that. But I do want to assure you that we are looking at it from a quality perspective and not just a quantity perspective.
Great. I'd be interested in seeing that. And just kind of generally, are people, when they leave custody, are they stabilized, or what trends do we see, or is it just all over the map?
We could get you some information. I know that Tony mentioned that our recidivism rate is, lower for folks that interact with our TSP team, but.
Yeah, I think that's a great question. I think it is one that we would probably have to get back to you. But to your point, I mean, again, the difference between, again, it's a bit redundant, but the transition planners and their impact, they create that margin where it's 16% for us and 23% for the county. So it's definitely, there's a connection there.
One thing I would say is that, the county is the safety net, and we do want it to be like a trampoline. Not a trap, a trampoline. And so we know that people coming in are unable to get health care. Although here in Oregon, we've affirmed that health care is a fundamental right in our Constitution, we know that people aren't getting that care, and it's part of the reason likely that they're ending up where they are with us. So our goal is that although nobody wants you to be staying with us, if you are, you're going to get the best health care, mental health care, dental care that you can, and we're going to have measures in place to make sure that we're delivering on that goal.
I really appreciate that. And I'd love to see it represented in our budget, because it's just like if people are getting stabilized or getting care, that would be great to know. Did you want to respond to my question?
I did.
Tell me about the health outcomes.
Good afternoon, Christian Elkin, County Budget Director. I use she, her pronouns. One of the things I wanted to remind the board is that we made a change in how we delivered the program offers this year. So we asked all of the divisions to up-level their outcomes to the division level and in the division narrative, and that the program offers represent outputs. And so it is very intentional that there's only outputs in the program offers, so you have a sense of what the resources take to deliver those outputs, but then go to the department division narrative levels to find the outcomes. And this is our first year doing that, and I know from the time that the budget was submitted until we get to the adopted budget and further along as we think about the strategic plan, that all that work's being revised. And so I know you all have some stuff that you'll probably want to put in there, post that you'll see in the adopted budget as well. So we're working really hard to up-level to that outcome conversation.
Great, I appreciate that. I mean, I did start by looking at the outcomes, which we're pretty focused on some specific things. So, and it's not a criticism, I was just wondering if you kept the data about general health aspects versus, I say, some of the outcomes are around overdoses, which are very important things, but it's also this larger thought about people coming in. I know a lot of people have a whole host of health-related issues when they come in, and hopefully when they leave, things are a little bit better and they're being handed off to another care provider.
Fuka, I want to assure you that we absolutely agree with you on that. I think there's to Valdez's point, there's a variety of different things, obviously, that we're tracking, we're looking at. I think that the two, especially when we think about historically, some of the things that have jumped out. If you remember, there was the NIC, the National Institution of Corrections, that report that called out some things as related to suicide deaths in custody. So that's why I think there was more of an emphasis on overdose and suicide attempts in our KPIs. But absolutely, to your point, there are definitely a host of other things that we captured that we can also share with you and illustrate. So.
And my last question is not so much a health-related question, but it's more like an ops question, so this is probably yours. I think I saw that you presented that you have like 1,000 contracts annually that the department, or maybe that was an earlier presenter.
No, I think that was an earlier presenter.
Okay. And maybe this is a question, if we're wrapping up here, just with 1,000 contracts, I'm just curious about what we're doing in terms of operational efficiencies. If it's the same contract over and over again, how we operationalize that in a way that we're not doing the same 1,000 activities the same year over year. Is there a way to automate it or more automate it? And then my other question is related to all those contracts. And I'm sorry I didn't ask it when the right people were here. So the other question I have is, in those contracts, when was the last time we had like a review of any of the performance metrics and how our contractors are performing? It's just a lot of outside contracted services, and if we're going to ask the tough questions of our county staff, I'd expect we'd want to have the same level of oversight over our contracts.
Yeah, definitely. A couple of thoughts. So it's not quite 1,000 contracts, but it's over 500. And we have a contracts team that is looking at opportunities across the department to automate, but it's also a feature of the conversations that we've been having in shared services, because there's that opportunity then at the county-wide level. So a thought there. And then it's funny that you say that, Anthony. I were just having this conversation. He was here earlier about, in opportunities across, but also in the work that we're doing in behavioral health, looking at the contracts for both spending, but also performance and, and how to talk about those things. Yeah.
Thanks.
And I would say, Corrections Health, our only contracts are we have agency staff who are contracted, the HR managers, those contracts, but then we work with our Corrections Health partners. And one thing I'm really excited about is because of the rising cost of outside medical and the stewardship that we're, leaning in with utilization management and looking at the care that was sent out and having those conversations, more frequent conversations with them to get that data and look at it and then tease apart why did it go out, and are there internal investments we can make to keep the care in-house so we don't have to rely on the outside care in the first place. And again, our clinical team is putting together some ideas for some interventions and technologies and training that we can do to keep it more in place. So that's just one way we're trying to squeeze all we can out of the contractors, not only as facilitators, but as advisors.
Okay, thank you.
Yeah, majority of my questions were asked already, and they were centered around just the level of care that we're providing to just our community members that are under our care, specifically around behavioral health, and then the deaths in custody as well. And then I had a question around just the trends, so I'm excited to see just the results from the mapping from the folks that are in our care. And then, as you know already, fully supportive of the TSP, the work that the TSP team is doing, and just looking forward to seeing just the collaboration with the work that Steve is doing or has started or has been doing. Yeah, so I don't have any additional questions outside of very supportive of the behavioral health officer position and looking forward to supporting that, because I think that's a key element that's missing as far as the needs within our community, specifically within our jail system.
Thanks, Commissioner Jones. And one thing I just want to say that you sparked for me is also just want to give a shout out. We talk all the time about our relationship and interagency collaboration with MCSO, but big thanks to Director Pena from DCJ, Dr. Kyle Armstrong Romero, James Hartman at the Donald E. Long. The relationships we have with them is so important in caring for those 25 youth over there, and we're really proud of the team of our small but mighty Corrections Health team that's embedded there, both nurses, mental health consultants, and providers and dentists that rotate through on Wednesdays.
I had a question from the previous slides. There is the new behavioral health one-time only request that you mentioned, and it's around doing outreach around the Central Library. I'm curious what other behavioral health services you all provide that are geographically specific like that.
Commissioner, can I have them speak to that tomorrow when they come?
Yep.
The behavioral health team? Okay,
Yep,
perfect.
absolutely.
Thanks.
Thank you.
Okay, it sounds like we've had a chance to ask questions. Thank you so much for the presentation. And I just want to say thank you also for the work that's been happening. I think, we've been having these conversations about Corrections Health over the last 4 years, and really what is needed to staff efficiently, what is needed to really fill those vacancies, what is needed to improve the relationship with the corrections deputies and the sheriff's office in terms of what's happening there. And I just really want to say how pleased I am with the steps that have been made, and especially as we're thinking about different impacts because of the budget, how we can continue to provide the best possible care to folks who are in our custody. So thank you all for this work. We are closing up for this morning.
I actually have an amendment to share.
Great, I was going to say that. So this is, so just so you guys know, so I will always say before we close for the morning, are there any budget amendments or note that anyone would like to bring forward? So I will always, I have that in my script, so.
So I'm just going to share an updated budget amendment 1B for workforce investments, adding offsets. One is DCM workday support, and the other is the North Portland Day Center. So I firmly believe, after visiting that site, that it is inadequate to provide the services that people need, which is then having an outsized impact. And I would love to work with the chair and the department to find and the community to find a more appropriate space to provide day center services in North Portland. So I am using it this year as an offsetting cut for my workforce investments.
Who is that run by?
It's run by Do Good Multnomah, and I just want to say they do a fabulous job with the small site that they have to use. So this is not a reflection of the provider. It's a reflection of day centers should be big enough to accommodate more than 10 people.
And have outdoor spaces. So appreciate that. Any other amendments or notes? Okay, we will be back here today at 1 p.m. to have more Health Department budget discussions. So we will see everybody at 1 p.m. today. There being no further business, we are adjourned.